Hello, everyone. This is Krista Martell from the Well Project, and I am very excited to welcome you to the second webinar in our 2017 Watch series. Today, we will be presenting Undetectable equals Untransmittable, Building Hope and Ending HIV Stigma, and that is otherwise known as U equals U. So I'm going to give everyone a minute to say hello, and if you want to enter greetings in the chat and say where you're from, that would be great. It's always nice for our presenters to be able to see the diverse places that our attendees are from, and then we'll get started in just a few minutes. And for those of you who have not been on one of our webinars before, just a reminder, and we'll mention this again, that you can use the attendee chat to put in any questions around the webinar and during the presentations, and we will collect those during the webinar and pose those at the end to our panelists. So it's great to see so many names. Many of our Community Advisory Board members from Nigeria and India and Ohio, I see. Hello, everyone. Good morning, everyone. I see more names entering. Okay, so we are going to get started, and we just have a few introductory slides before we get into our presentations. So once again, welcome everyone to our second webinar in our 2017 Watch series. Just a note about the Well Project. We are a nonprofit organization with a mission to change the course of the HIV/AIDS pandemic through a unique and comprehensive focus on women and girls. And we do this by leveraging technology in hopes of improving health outcomes and increasing the quality of life for women and girls living with HIV. And our goals are to provide accessible and comprehensive information, community support, and advocacy building using our web platform at thewellproject.org. And I will now introduce Bruce Richmond, who will tell you a little bit about Prevention Access Campaign, who is a partnering organization with us for this webinar as well as for the Well Project.
Hey, thanks, Krista. I see some of our steering committee members online, so it's great to see you all. So Prevention Access Campaign was started by a community of people living with HIV and then also allies. And our goal is to get the information out that's radically at odds with the status quo, and it's revolutionary for the field, but it's largely unknown and very uncomfortable for people sometimes to say it, that people living with HIV on effective treatment do not sexually transmit HIV, or U equals U. And that was started really jump-started with a consensus statement, and that was really the genesis of this movement that's now worldwide with just incredible people. So I'll look forward to telling everybody a little bit more about that later on.
Great. Thank you, Bruce. And I also just wanted to give you a little bit of information about WATCH. WATCH stands for Women's Advocacy and Treatment Coalition on HIV, and this is an ongoing HIV treatment advocacy and capacity building webinar series. This year we expect to offer 4 to 5 webinars over the course of the year, and as I mentioned, this is our second one. Different from other years, we are issuing certificates for each webinar instead of just the entire series. And so in order to qualify for that, you need to take the pre and the post test, as well as either attend the live webinar or view the recording. We will send out a message to everyone who's registered as well as attends the webinar when the recording and then the resources, including the slides from today, is posted on our website. And really the goal for this treatment advocacy series is to provide you with the information, not only to provide you with the information for yourself, but to give you the tools, including slides and a fact sheet, to then go out and share that with others. And so we hope that you are able to do that. Okay, so now for a few more details. This webinar will last for 90 minutes, and as I mentioned, we'll have the Q&A at the end. We can use the live chat box to your left, which many of you are using, to enter in your questions. And as participants' lines are muted, and we typically just keep it that way. If there's a request, we can possibly unmute at the end. All right, now for the good part. I'm very, very honored to have this great panel of speakers. We have Dr. Benjamin Young, who is the Senior Vice President and Chief Medical Officer of the International Association of Providers of AIDS Care. IAPAC is the abbreviation. As we've already heard from, we have Bruce Richmond, who is the founder and executive director of Prevention Access Campaign, which is the undetectable equals untransmittable. We have Gina Brown, who is, a little title there, Community Advisory Board and WRI member for the WELL Project, as well as her work in New Orleans, which she will tell you more about. And we have Maria Mejia, who is a global ambassador, community advisory board member, and a Girl Like Me blogger for the WELL Project, in addition to many other affiliations. And all the speakers will give a brief introduction of themselves before they speak. And I am Krista Martell, the executive director of the WELL Project. Okay, so now I'm going to give you a brief agenda overview. We will first hear from Dr. Young, who will kind of present the U equals U science and research and how the campaign came to be. Then we will hear from Bruce, who will talk about the campaign a little bit more and give you more details about it. And you'll get to hear how many organizations have partnered and endorsed the consensus statement. Then we will have some panel questions with our two women, Gina Brown and Maria Mejia, who will answer some questions about their experience with the campaign and hearing about U equals U, as well as their experience on promoting awareness around the campaign. And then we will have the Q&A. Okay, so now I'm going to hand it over to Dr. Ben Young. Thank you.
Well, thank you, Krista, and thanks everybody on the call, including members or attendees from all over the world, India, Nigeria, South Africa, and across the United States. It gives me great pleasure and quite an honor to be part of this panel to discuss U equals U. Again, my name is Ben Young. I am very proudly a career-long HIV care provider, researcher, clinical trialist, and human rights advocate. And I am the Senior Vice President and Chief Medical Officer of the International Association of Providers of AIDS Care, or IAPAC. IAPAC has been working in the HIV treatment and human rights area now for about 30 years. And again, very proud that IAPAC is one of the organizational supporters of the U equals U campaign. Over the next 15 or 20 minutes or so, I'd like to take us through the science that underpins the U equals U campaign, and to set that up, it requires a little bit of an understanding of where the science has come from and where we're at. And in doing so, I also would like to cover some of the more operational and policy issues that make or that give us an understanding for why U equals U is so important. So to start this conversation, it's important just to start with some basics. And this one slide really sums up most of it, which is to say that when someone living with HIV is taking their medications and their viral load has reached undetectable levels, it means that that person cannot transmit HIV to a partner who's HIV negative. And so in the community, community members, advocates, scientists, and experts refer to this as the term undetectable equals untransmittable, or U equals U. Again, a brilliant educational and advocacy campaign, again, that Bruce founded. And again, we'll hear from him, or again from him in just a few minutes. The basis of U equals U is what we on the science and policy side call treatment as prevention, or as I call treatment is prevention. That is to say, HIV treatment prevents disease, it prevents progression to AIDS, it prevents serious diseases like cancer and tuberculosis, and HIV treatment prevents transmission. So this means that, again, the treatment as prevention, or TAP, is the basis for the way we think about U equals U. And it not only is treatment as prevention important for the individual from a health perspective, but it also means that it's a strategy that we can think about for lowering the risk of HIV infection and spreading HIV to others. So this means, again, very specific terms, and why this works is that HIV drugs reduce the amount of virus in body fluids, blood, vaginal fluids, semen, and in doing so, this means that that individual is very much less likely to transmit the virus to others. This also means that in couples, mixed status couples or magnetic couples who want to have babies, they can have babies by having sex without condoms, the old-fashioned way, as we say. So when we say these kinds of things, again, the basis of this is saying that when the risk of infection has everything to do with the amount of virus present in the body fluid and the amount of body fluid that someone's exposed to. So HIV drugs or antiretroviral therapies work by preventing the virus from making copies of itself or reproducing. And when an HIV treatment works, the virus is unable to reproduce. It does not infect new cells in the body. And when the viral load remains low and undetectable, the immune system either stays healthy or can recover, and then those individuals are less likely to transmit HIV itself. Now, with all that said, it's important to know that today's therapies, as good as they are, do not cure HIV. And so even when the viral load is undetectable, the first U of the U equals U, the virus is still present and resting in many cells in the body. And so stopping the medications will eventually lead to the return of the virus in body fluids. But again, to emphasize this point, having an undetectable viral load means that there's really no virus or a trace of virus in the body fluids that transmit HIV. So it's now been 9 years since this landmark scientific consensus statement from Switzerland, hence called the Swiss Consensus Statement. It was published in January of 2008, where a group of HIV scientists in Switzerland working in their public health departments agreed that someone living with HIV who had been on treatment for at least 6 months on treatment and had an undetectable viral load for 6 months had a negligible risk of transmitting the virus to others. I actually want to read to you the actual statement, which says that during effective antiretroviral therapy, free virus is absent from blood and genital secretions, and epidemiologic and biologic data indicate that during such treatment, there is no relevant risk of transmission. And so just say this again, no relevant risk of transmission. And that's the basis for that's really kicked off both the science and the public policy that leads us to think of HIV treatment as prevention. Now, more recently, there have been several large clinical studies that have furthered the science and give us a lot more confidence in the statement that treatment is prevention. Probably the biggest and most important of these at the time was called HPTN 052. 052 was first presented its data now, more than 5 years ago. It was a study of international study of more than 1,000 mostly heterosexual mixed status couples. And it looked at the effect of treating individuals as to whether they transmitted the virus to others. Importantly, or within the couples, and importantly, they were able to do genetic fingerprinting to ask, if someone did become HIV positive, was the virus that the previously HIV negative person acquired, was it related to their partner, or was it related, or was it derived, or was that person infected by somebody else? And so after looking at this large group of sexually active people, they found that taking HIV treatment dramatically reduced the risk of new infection. In totality, the reduction in risk was about 96% compared to people who were not on treatment. But the remaining 4%, the remaining cases were always in cases where there was a reason for the transmission. In other words, there were 3 cases of transmission. In one case, in all cases, the individual either had a detectable virus or had stopped taking their meds. And in another case, the person hadn't yet started taking the medications. So it actually proves that what we know about medications, if you haven't started taking medications, you can transmit. If you're taking medicines but then stop taking them, you can transmit. Or in the event that someone has treatment failure because of drug resistance, the virus becomes present, and again, you can have transmission. But as long as HIV medicines are working and the virus is suppressed, there's no transmission. So again, in the study of 1,000 couples, there were 0 cases of transmission among people or from people who were successfully treated with viral suppression. So HPTN 052 changed the entirety of the way we think about HIV treatment as a prevention tool. And the problem, though, is that because of the decades of public policy and stigma and discrimination that we'll talk about in a moment, that information was not well accepted nor well understood outside of the experts who are working in the field. And we point out here that mainstream media and even the medical media often confused, or even, I would actually say, deliberately misled people around what these results meant. And as a result, many people living with HIV were not aware of both this exciting but frankly fundamentally important advance in science. And then just last year, we learned the results of the PARTNER study. And I think this is the study that really cemented in many people's minds the power of HIV treatments and undetectability equals uninfectious. And this is a study that looked at mixed status couples who are both straight and gay. At the study entry, the positive partner had to be on treatment, but actually only had to have a viral load less than 200. So it was a huge study and a heroic study from the view of the participants, where they did very, very detailed sexual diaries. When did they have sex? How often did they have sex? Did they use a condom? Was there an orgasm or not? And so on. And with that kind of very detailed sexual diary, after nearly 60,000 sexual encounters among these 1,100 couples, 0 cases of HIV infection from the positive to negative partner. 0. So these results were published now, 2 years ago, and yet we still haven't really fully embraced the implications of this study and the large studies that preceded it. So why is that? Well, it takes a while to change cultures. It takes a while to change attitudes, and even more so in an environment, I would say a political environment, where we even question the very nature or validity of science. I think these are both attitudinal and political times that really make it difficult sometimes to change deeply held beliefs. I actually think that part of the core of this has been the decades of HIV prevention being limited to condom education, and really only male condom education. And so anything that might somehow be seen as a threat to the importance of condoms might be seen as something that was something to oppose or to fear. And as a result, having treatment as a way of reaching undetectable viral loads, and therefore as a way to prevent transmission, was very difficult for many agencies, especially public health agencies, to accept. And it's all the while important to recognize that treatment as prevention is not a way to prevent pregnancies and not a way to prevent sexually transmitted infections, with the exception of hepatitis B. So condoms do prevent pregnancies and do prevent sexually transmitted infections, but HIV treatment as prevention does not. So let's spend a couple of minutes thinking, at least laying out some of the issues as to why U equals U has been difficult to communicate, and why many people don't know about U equals U. And some of this is laid out on this slide, which talks about the intersectional forms of stigma, and that is to say that intersectional means that there are different kinds of stigma that derive or that attack different aspects of communities. So people living with HIV or vulnerable to HIV often have or the same people where sexuality itself, not HIV, carries its own stigma and judgment. So that is to say that, for example, women of color, older women in general, often face their own issues of stigma and judgment. Transgender people especially. When it comes down to sexual lives, we have a lot of difficulty in talking about these kinds of issues. And so again, recognizing that means that treatment as prevention also deals with these multiple layers of stigma, judgment, discrimination. And case in point, again, doctors and healthcare providers often have difficulty addressing these kinds of issues when you have these onion layers of stigma. So one recent study showed that 40% of women in one study had not yet been told about U equals U. In a different study, participants vastly overestimated their own transmission risk, again, reflecting that they were unaware of U equals U. And this has important implications in terms of how one judges themselves and has or deals with issues of self-stigmatization. There's also this daunting problem of power dynamics, especially as they affect women, both here in the U.S. And abroad, elsewhere. So women often cannot demand that their partners use condoms due to uneven power dynamics, fear of violence, the fear of economic retribution. And it follows that women may not be able to ask about their partner's HIV status, never mind their treatment status or viral load. So this points out that we need a lot more understanding and research into the ways that U equals U may be affected by power dynamics, and how U equals U may be a way to change the way that women access care, how they can self-advocate, and ultimately a world that is more just and equitable. One important area for women where there is less information is around breastfeeding. And so while we know that HIV treatment effective HIV treatment can eliminate vertical transmission of virus, there might be some risk still, and that one comes from the fact that we don't know the safety of HIV medicines in breast milk as well as we do the safety of HIV in the blood, for example. There are also other factors that affect HIV transmission through breastfeeding, which can include mastitis, which is a breast infection, and so on. Breastfeeding is also complicated by the fact that in many parts of the world, especially low-income settings, these are places where the access to refrigeration or clean and safe water is unavailable. And so in those places, breastfeeding remains recommended by the World Health Organization because of the inability to make safe formula for babies. So it's an area that is, at the moment, of some degree of uncertainty. It stands to reason that HIV treatment should lower the risk of transmission through breast milk. But there's not absolute agreement among the experts in women's health around this issue. I argue, and many others do argue, that as a matter of self-determination, women should be given all the information necessary to make their own health choices, and should be supported to continue taking their HIV treatment. This is called Plan B Plus by the World Health Organization, that women who are living with HIV who are pregnant should be treated, and they should be treated after the babies are delivered. This is both important for the health of the mother as well as the health of the baby. So again, breastfeeding is an area of some understanding or lack of scientific consensus. Now, one of the areas that I've been working a lot on recently has been the issue of HIV criminalization. This is the topic where people living with HIV may be prosecuted and imprisoned for simply having sex. And as of last year, at this time, 72 countries, including the United States and more than 30 states in the U.S., have laws on the book that make it a crime for people living with HIV to do things related to sex that are not crimes for people who are HIV negative. These laws are what I call state-sponsored stigma, state-sponsored discrimination for people living with HIV, and are not supported by the science that we now have. Those same laws also make it more difficult to get people tested. It makes it more difficult to get people into care or onto treatment. It also makes it less attractive for to enter in the field to take care of people living with HIV, because some healthcare providers don't like taking care of people who might be viewed as criminals. And in the end, those laws don't account for the new science of HIV transmission and the effects of undetectable.
Okay. Sorry, Dr. Young, your audio just went out, just when you switched to this last slide. So maybe you could start over.
Can you hear me now?
Slide. Yes, I can.
Yeah, can you hear me now? Okay. What happened there?
No,
so
okay, yeah, it's good.
Yeah. So again, just to start over on this slide, so many of us working in this field, both from a scientific and human rights perspective, oppose laws that criminalize people living with HIV, again, for a wide range of reasons. And it's important to recognize that, especially that women may have difficulty getting their viral loads undetectable for reasons of difficulty with accessing care, accessing testing, because it's not uncommon for women to prioritize the health of their children or others over their own, because women are subject to higher rates of intimate partner violence, poverty, social instability, and so on. And all of these things make it difficult to successfully access care. So we believe that criminalizing people on the basis of their HIV status is never appropriate, regardless of viral load, and in my opinion, again, a clear violation of both science and human rights. So let me just summarize all of what I've said, and hopefully in ways that are a little more clear. The bottom line in all of this is, especially recently, there's increasing awareness that having an undetectable HIV viral load means that people living with HIV do not transmit the virus. Hard stop. That appreciation has a dramatic impact on both public policy as well as the public and individual perceptions of what HIV is and what it means. And HIV stigma, and I'll add to this, HIV discrimination and HIV criminalization, in my opinion, are the biggest barriers to ending the HIV epidemic now in a time when we actually have the tools to actually make AIDS a rare thing. So appreciating that's the role of stigma, it's important to break down stigma whenever possible by providing support, information, and advocacy. And I think, and again, we'll hear about this through the rest of the others in our panel, that U=U is really an important and critically important tool to address HIV stigma. I think this is my last slide, and that is to say that researchers, clinicians, and the community must continue to examine the promise and impact of HIV treatment as prevention. And the science that we have, again, strongly supports, I would say unequivocally supports U=U. And we need to make sure that all people living with HIV, those vulnerable to HIV infection, have access to both life-saving treatment, but also this life-altering information so that they can make informed decisions about their own sexual health and lives. So I think that's my last slide, and I'm going to turn over the microphone to our distinguished friend and colleague, Bruce Richmond. Bruce?
Great, thanks, Ben. Oh, hi. So was that Krista? Did you want to?
Yeah, I didn't know. Should I jump in with? We have a poll question that we were going to ask real quick before Bruce goes. So I am going to just start the poll, and basically the question is, how did you hear about U=U? And we'll give everyone a few minutes to answer how they did. Maybe it was you've heard about it for a while, maybe it was through this webinar or another advocate. All right, so it does look like other advocates is currently at the highest percentage, at almost 40%, or other organizations. And we're glad to hear that we've had an impact, and Prevention Access has obviously had a huge impact, and then social media as well. Okay, we're going to close up this poll, and this always helps us as the presenters to kind of gauge where the information is coming from. Thank you. All right, and Bruce, I'm excited to have you speak. Thank you. And thank you,
Excellent.
Dr. Young, for your awesome.
Yeah,
my pleasure.
Dr. Young, your presentation was fantastic. It was really clear, and it hit on a lot of the points that we like to cover in our presentations. But you did it more eloquently and more clearly. So really appreciate it. Let me just make sure I can move the slide forward. Yes, I don't see the button on here. So can you advance the slide, please?
Yes, I'm doing that now.
Okay, perfect. Okay, thanks. So the campaign, back in 2012, I learned that because I was undetectable, I couldn't transmit HIV. My doctor told me, and there really wasn't anything at all that I could find to support that. And I asked him if he'd put it in writing, and he said no. And I started learning that other people didn't know either. Some did, and it kind of was like the people who look like me, white, cisgender, gay male with stable health insurance and food security and housing, and it started to see that this pattern of folks who were being excluded from this very important information that actually helps all of us and provides this kind of hope and ends this internal and dismantles internal and external stigma. So we started this campaign and really started organizing in 2015, but we launched in 2016, and a group of us came together, people living with HIV, and we reached out to the researchers and said, your research is groundbreaking. We've heard about it through individuals, clinics, and I spoke to heads of clinics and heads of medical associations, and people were confirming that this is true. Some called it the big secret in medicine. We needed to get this information out because there was this barrier between the science that's groundbreaking and changes lives and impacts the field in unprecedented ways, and then the people and the field that the science was intended to benefit. So we brought this community together, and our mission was to get this message out, U equals you. U equals you is sort of a term that came from a bunch of different people, but really wasn't out there yet. Undetectable is untransmittable. Next slide, please. You could advance. Okay, so now the community is pretty huge. These are some examples of organizations that have joined us to endorse the consensus statement. You can see groups like AIDS Map and International AIDS Society, and U equals U. It translates into I equals I in Spanish and Italian and in Brazilian Portuguese, and it's N and N, and in Dutch it's H and H in Macedonia. So it's really kind of been embraced by these organizations, and the way that we get the message out is by providing information to those organizations who then provide that information to their communities. We don't create campaigns. These are all campaigns created by other organizations. They then educate folks. So starting in about last summer, when our partners started to sign up, we started to see campaigns coming out. One organization called Terence Higgins Trust in the UK was really a global leader. They were working on this, individually in the UK, and were really the first to make a statement. So we're really honored to be working with them. Okay, next slide, please. Okay, so the consensus statement was like a holy grail for us. It was an advocacy tool that we could use to get influencers to commit to this message, to say, yes, it's true, we know it's true, and we feel comfortable putting that in writing. And so we finished the consensus statement just before Durban last summer, and it was created by us and the researchers together. So it was people living with HIV and researchers from the main studies that Dr. Young had talked about, HPTN and Partner, and also a study called Opposites Attract. So these were the researchers there from Australia and Switzerland, and Denmark and the United States. And actually we worked with the author of the Swiss statement. Also, it's Dr. Young pointed out, the first document to clarify this in writing. So now, so we took that statement. It was pretty rough back in the summer. New York City Department of Health and Mental Hygiene came on first. It was really exciting when they joined, and then NASTAD, National Association of State and Territorial AIDS Directors, joined really early on as well, and then Housing Works, and we kind of had Housing Works from New York, which is a major partner of ours now. But it was rough, we saw a lot of the things that Dr. Young was mentioning. A lot of folks held stigmatizing beliefs about people living with HIV and people who are vulnerable to HIV. And we saw some ugly stuff, and we had to fight through that, and we had to force, in some cases, people to tell the truth. They would sit across from heads of clinics and they'd say, absolutely, I agree with the science, but my patients won't understand that to stay undetectable, they need to stay on treatment. So we talked to their patients, and they want to know. And some of them are pretty smart, but there's this kind of blanket license within medicine and public health that, you want to do the best for your patients, and part of that is to control what information they get. We found that was we needed the information, and we thought we wanted everyone to have it. So we work with partners. We have 280 partners from around the world, from 34 countries. The consensus statement has been translated into 11 languages. It's about to be 12 languages. We work with individual actors, many more. So there's about 350 sort of advocates and organizations around the world, but they actually have, some of their organizations haven't signed on yet. But they're, individuals in various countries are working to get their ASOs and their other AIDS organizations to sign on. So I hope folks on this call can end up being U equals U advocates and work to get for change in your communities. So and as I was saying, it's really, the campaign is really an information campaign, and our community is incredibly diverse and amazing and wonderful. I mean, every day I have the most incredible conversations with people from around the world, from all different backgrounds. And we since the beginning, we've been working with Positive Women's Network, Hive, which many of you know is a hub of positive sexual and reproductive health in the U.S., Trans-Latina Coalition, the Latino Commission on AIDS, some Southern AIDS Commission working to end HIV epidemic in the South. There's the Africa and Black Diaspora Global Network on HIV and AIDS, the Body.com, Desmond Tutu HIV Foundation in South Africa, the Maori Indigenous and South Pacific HIV AIDS Foundation from New Zealand. Just a few more, because we're really proud of these relationships of organizations that have been supporting the message and supporting people living with HIV by standing up and saying that this is true. NAM, AIDS Map, many of you know as a major trusted source of information. It's where I went when I was diagnosed in 2003. Then Sishin from Nigeria, and then Jyoti, I see is on the line, brought in the Beyond Positive Foundation from India. We're so excited about that. And IAPAC, Dr. Young's organization, we were thrilled to have them on. So the list goes on, and I'm sorry if I didn't mention your organization that you're on the call. It doesn't mean that you're not important. We have just a phenomenal group. And it's really important for us to stay together to show that we are a united community. It's really important to have these sign-ons and to have these infographics created so that we can show to other folks that this is real, and to help them feel comfortable with this in their own lives as well as in their own advocacy. And the reason we do this, and Dr. Young, talked about this a lot earlier, is that this is an unprecedented way to break down stigma. And it's providing hope. It's changing lives. I mean, the kinds of stories, and I know we can talk about this later as well, is kind of stories of what people go through when they learn this. And we're surprised. We're so surprised all the time to hear that people, even in positions of leadership within our own positive community, and people that are working in the field who are HIV positive, learned about it from this movement. They didn't know before, and it gets me furious that I learned in 2012. And it took this. So in many ways, we don't want to blame and shame people, but we want to know what happens. we need to take a really an honest look, and not just at the system and at the power structure in AIDS Incorporated, but also within our own positive community, and that's going to be hard to look at. How did some of us know, and how did some of us didn't, and how did we talk about stigma within our own communities? Yet every information site was saying we're still a risk. So that's something that we can address down the road. But in the meantime, we hope that people will join us and continue to tell the truth. And we're here for a lot of support. And, we'll go over some ways that you can get involved in a little bit. I think that's it. Thanks for letting me go through all this.
Thank you, Bruce, so much for giving that excellent overview of how this all came to be and your experience so far with everything, all the work. Bruce is working so hard to get this information out, and it has been amazing to see how far it's gone in such a short amount of time. So I do see that we've been having some audio and visual difficulties. The PIN number, Maria, you put out there is actually the presenter PIN number. So I'm just trying to find the attendee PIN number, which many of you probably should have, but once I have a second, I will put that up there. So if you can dial in and you have the ability to do that, that's probably your best bet for the audio. In terms of visual, we invite you to refresh the screen if the slides are stuck. So we apologize, and we'll definitely be in touch with customer service to let them know. Okay, someone just, Marcus has just posted the PIN number and phone number for the attendees. So, okay, so next we are going to hear from our amazing panel, and we're going to have a panel discussion that is going to be led by Bruce with Gina and Maria. But first, I'm just going to I'll ask Gina to start, just to give a brief introduction of who you are, and then we'll move on to the questions and then we'll get to the attendee questions as well, which we're gathering. Thank you.
Hello, this is Gina. How
Hi.
y'all doing? A little background on me. I am a woman living with HIV 23 years, been working in the field 15 years. And I am a community organizer with the Southern AIDS Coalition and a new CAB member of the WELL Project, and I'm really happy to be here.
Thank you so much, and we're so happy to have you join our Community Advisory Board. And Gina's also been a longtime member of the WRI, which is the Women's Research Initiative on HIV/AIDS, and so she is a great friend. And Maria, if you want to give a little introduction.
Hello, can you hear me?
Yes, thank you.
Okay, hello everyone. I'm very honored to be here with all of you today. My name is Maria Mejia. I'm a woman living with HIV for 29 years and been in service as an advocate and activist for almost 18 years. And I'm very, very happy to be here in this very, very important and historical webinar.
Thank you. All right, so I'm now going to hand it over to Bruce, and he has some questions that he's going to pose to Maria and Gina, and then we'll jump in with some of the questions.
Excellent. Hi, thanks. And this is such an honor because both Maria and Gina are steering committee members of United U equals U, and have been involved for such a long time. Gina and I were on an HHS Facebook live chat back at USCA, and last September we met there. So, and Maria and I have been really active on social media and met at Positive Living. So I'm excited to ask these questions and engage. So the first question is, what was your first reaction to U equals U, and how has it changed over the past year or so? And have you seen a change in how people are receiving the message in your advocacy? So your first reaction, and how has it changed? And what are people? How are people receiving the message? Has there been a change in that? Who wants to go first?
This is Gina.
Are you ready?
This is Gina. Yeah. For me, when I first heard the message, I wasn't really skeptical. It was more of wanting to know more. So I wanted more information before I was comfortable enough to really start talking about it. And I was fortunate enough to meet Bruce, and we connected over a shirt he was wearing. And we started having a conversation. And the way he explained U equals U, it made me want to go and do even more in-depth research. And everything that he said in our conversation, I found to be true. So it was like, all right, now how do you talk about it to other people? How do you bring the message forward? And because a year ago, I didn't know as much as I know now. I didn't have as many conversations. But today I have conversations every day about U equals U. Right now I am doing SAC is having a lead academy training, and I have a group of women in a conference room, and at 2 o'clock we're going to go through U equals U, but all morning I've been talking about it. So just trying to really get people to buy into it and to understand what we're saying, and to know that this is not something that somebody just thought of in their sleep and woke up and said, oh, we're going to say this. This is actual scientific data that backs up everything we're saying.
Hello, this is Maria.
Maria,
and to a question that Bruce. Hello.
Yeah, hi.
Yeah, hi.
Go for it.
Okay. Yes. To the question that Bruce asked. Well, in my case, I am a little skeptical always with information, because like Gina said, it's not that I was against it. It's just that I wanted to research, and it took me approximately a year to the internal stigma that we have sometimes. Of not feeling infectious was a very, very it was very hard for me to believe that I could actually not be infectious by being undetectable. I have been undetectable for 18 years, and I knew that. I had been sharing in my international groups that I founded the information of the partner study 5 years ago, and but I always in everywhere I spoke, always talked about the low percentage of transmission, but I was just not able to actually say that we cannot transmit HIV if we're undetectable for more than 6 months. I just couldn't do it, so I started observing Bruce, his passion, other advocates joining, and I even, after joining the International Steering Committee and the national one with Bruce, I told Bruce that I was so sorry that I was not with him since the beginning, but that everything was a process for me, just like with PrEP. So now I could say with much pride, and it is up to us to advocate for ourselves and for others, and to let the world know that we will not allow anyone to tell us that we're infectious anymore. Because if they're working for against stigma like we are, they should join us, especially with all these important people like Dr. Ben Young, which is someone that is a friend and that I admire, and so many organizations worldwide that are backing us up. We have to all join together, and if there's providers that I continuously see, that I talk to, saying that it's not correct and all these things, we have to, with love, let them know that the science is backing us up, and that we have to join together to finally release us. And mind you, I do not want to put anyone that is detectable. Hello?
Hi, we can still hear you, Maria. Are you there? Uh-oh. Maria, we lost you. That's not good. Okay, maybe, Bruce, we'll move on to the question.
The next question.
Yeah. And hopefully, Maria, we can
get
on.
And then,
Thank you.
Okay, sure. So the question is, you have a good story of a response that you got to sharing the message that said to you, yes, this is why I share this message. So like that aha moment, this is why this campaign is so important in building hope and fighting stigma.
So,
Bruce, this is Ben. Can I jump in just? Oh, sorry.
No, go ahead, Dr. Ben.
I just wanted to add one other little comment to this as to why U equals U is so important. In part, it builds on everything you've just said, and we've been talking about. But the United States was one of the first countries in the world to embrace the idea that all people living with HIV should have access to treatment. That is to say that access to treatment wasn't determined by one's CD4 count or clinical status. The science around that, like the science around U equals U, has been very, very clear for quite some time. Nonetheless, of the 196 countries of the world, only 57 offer therapy to all. And that has important issues, important human rights implications, that people who should be on treatment are not receiving it. That means that people living with HIV are subject to increased health risks, particularly in places, or in many places, where those individuals represent, again, that intersectional issues of stigma and discrimination. So women, poor people, et cetera, are the very people who are most impacted by not having access to life-saving and health-restoring therapies. So U equals U, to me, not only is it an issue that's important around one's personal identity and deals with this very important issue of how one feels about their sexuality and love, it also is an important vehicle to actually ensure the human rights-based approach to offering important life-saving therapy to everyone. Gina, thanks for letting me interrupt you.
Great point. So, Gina, yeah, absolutely. I mean, we actually even heard a story from that the president of Uganda just learned this through someone from UNAIDS, very high up, and that this has it influencing him to think about their access policies and issues around access to treatment and care and diagnostics in Uganda, because this is a way not really as much about saving lives but more about actually using this as a way to end the epidemic. Unfortunately, our lives don't matter as much, and sometimes in some contexts. But so there is that benefit of how this impacts access to treatment and ensuring people have the option. So we hopefully see a change. And I think Gina, you were about to answer about the if you've had a sort of that aha moment. This is why I do this. This is why this message is so important.
I think for me, that aha moment came when I was talking to another woman, and I was explaining to her what U equals U means. And she looked at me and she said, okay, so if I take my medication exactly as prescribed and I become undetectable, that means that I can get in a relationship. And I kind of smiled when she said it, because that's exactly where I was at. I was thinking that, now that I have this knowledge and I know this knowledge is true, now I feel okay, I feel comfortable getting into a relationship, knowing that I can't transmit HIV, knowing that I can be in a loving relationship. But at the same time, I live in a state that criminalizes HIV. So you have, it's a double-edged sword. But at the same, but still talking to people about it and making sure that we're having those conversations, because maybe we can change the thinking or we can change the policy around that criminalization with some of the work we're doing. So my aha moment was when another woman talked about getting into a relationship, and then I realized I could get into one too. So.
And Maria, did you have any comments? Situation on when sorry, go ahead.
Yes, actually, I want to apologize. I got disconnected when I was trying to finish from the last question. The 2 points that I want to emphasize, and is that I don't want anyone that is not undetectable to feel bad or to feel infectious either, because I have a lot of people that write me and say, I feel bad, I feel like I'm not a part of, I feel like I'm infectious, and I tell them, listen, sometimes it takes years. I know people that it took years and then they became undetectable. Just continue to be healthy, continue to take your medication, to use the tools that we have available until you become undetectable. So this is the way that I see it in my aha moment. And what I have always preached as far as treatment as prevention, because I say if you don't believe U equals U, then you don't believe in treatment as prevention. So I say you're not only saving your life, but you're saving other people's lives. Not only that, but you're stimulating and empowering others to be adherent to their medication, which is so important for everyone, to prevent new infections, for stigma. This is, to me, one of the most important anti-stigma campaigns that exist. And it's very, very important that we back up the science, as we said, that we join together and unite. This is not a war. This has to do with humans that are living with a condition of HIV that can finally, I feel free. I feel that, that I am not an infectious person, as I said, and I feel that after being undetectable 18 years and having a negative HIV negative partner for 10 years, that is the reason why my partner remains HIV negative, and that is the reason why I am also alive, because I am adhering to my medication. And that was the aha moment when I realized how this was going to impact us not only nationally but globally as far as adherence and prevention and against stigma.
Thanks, Maria. That's really important. I think you're right. In the campaign, we need to get the information out, and we need to get it out now, and everyone needs to know. And we don't want people to start shaming people or alienating people who are not on treatment and not undetectable by choice or by circumstances that are out of their control. So this is a movement that we hope ultimately lifts everyone up and will ultimately provide more opportunities and more options for people, and also will dismantle stigma, which affects all of us. I think so. Gina, we wanted to talk about what's happening in the South. How are you seeing women accepting or not accepting the U equals U message?
So in the South, here in Louisiana, we're having a conversation. Some women are receptive to the message. They're really listening, and they want to know more. Like right now, I have a group of 8 women in the room that I'm doing a training with, and this afternoon we're gonna go in depth on looking at U equals U. And this earlier this morning we talked about it, and the first thing out of their mouth were, can we have a campaign? So we're going to talk about some messaging we can do around our area to get more buy-in and more support for U equals U. I don't know if it's being talked about all over Louisiana, all over the South, but I know that the work that SAC is doing, we're making sure that we're incorporating the message in all of our work. So we are on board with supporting the campaign, and we're supporting Bruce all we can, and making sure that as we give people the information, we're giving them correct information. So we have a lot of work to do in the South, but I think that we're we're on track to make sure that the message is out there and people are understanding the message. And if they have any questions, we can guide them to different Facebook pages, different publications where they could get more information about You Equals You.
Great. And I'm wondering, Maria, and with your community, you have a massive. Well, first, Gina, I want to say Southern Aid Coalition has been fantastic, and we're really excited to be working with you and Kafre and Nick, and we've gone through presentations and training, and I think it's awesome the way you've been reaching out to educate, raise awareness. And I know, Maria, you have a massive following on social media and have been so active in getting the message out in so many different creative ways and diverse ways to get this out. It was so exciting. What has been, how have you seen that women in your network are accepting or coming to terms with the message, coming to understand the message?
Thank you, Bruce. Well, the women are very excited, especially in places where there's really not a lot of education. And as far as HIV and AIDS, they've been receptive. They've been very excited. Like I said, it's promoting adherence. It stimulates them to be adherent to their treatment, because many of them were actually scared to start antiretroviral therapy because of lack of education, because they think that if they take their medication, they're going to that's what's going to kill them and so many things. So by example, I try to show them that you could live a very healthy life. So they've been very receptive. I have gotten a lot of, let's say, resistance from globally and nationally from certain people, certain activists, even providers, where they're telling me that I am not encouraging people to use condoms, and I tell them absolutely not. I'm encouraging people to use all the tools that are available. I say to them, basically, it's very simple. You equals you basically means you take your medication after a sustained pressed viral load for more than 6 months. You cannot transmit HIV, but I promote condoms to prevent other STIs and of course, pregnancy for women, and there's PrEP, and there's treatment as prevention. So I have gotten resistance, but with all the organizations that are backing up your campaign, Bruce, and even the information that we had from 5 years ago that actually I was sharing in my groups and everything, but I just, as I said before, I couldn't come to the terms of saying 0%, because in my mind, this is something that was embedded in me, from a standpoint of education, that there is also always a possibility. But no, it's the science backs us up, and that's what I try to tell the people that are resisting, like I did, because it took me approximately a year, as I mentioned before. So what we have to do is just continue promoting, using, as you said, different ways. My forte is social media, but everywhere I go and speak, I talk about You Equals You. In the street, I talk about You Equals You. I want to reach mainstream media, which is because sometimes we're like preaching to the choir within our own community, but of course it starts from our community. But we have to reach those places where HIV is not talked about. And that's right now one of my goals, getting those contacts, and we should all try to do that so it could get to mainstream media, to people that do not talk about HIV, so they could potentially, ask for an annual test for HIV as a routine test. And as I tell them, if you find out that you have HIV, look at all the people that are living and surviving and thriving with the condition. You get on treatment as soon as possible, because that's another issue. A lot of the times, still in some countries, they wait until your immune system is completely destroyed to start treatment. And I tell them, you have to have a good communication with your provider, but you also you have rights. And you have to if you have access to treatment and they're not putting you on treatment, you have the right to have a discussion with that provider and tell them that you want to become undetectable. You do not want to wait until your immune system is destroyed because you want to be able to be undetectable and HIV stops with us.
Great. Thanks, Maria. And I just want to point out that I appreciate when folks say my Bruce's campaign and that stuff, and I hear that frequently. And I want to change that. It's not my campaign. It's everyone's campaign. And Maria, you're on the steering committee, so it's as much your campaign as it is my campaign. And Gina's on the steering committee, and the Well Project has taken it on. So it's everybody's campaign. So it's ours, and we wouldn't be here. We wouldn't be having this discussion if it weren't for hundreds of people. I've been starting to try to list all of them, and it's incredible. So thanks for that, and it is ours. It really is, and I hope you feel that too.
You're very humble.
Yes, he is. Well, thanks. So, thank you. This is a really awesome panel and discussion, and I don't want to rush moving on, but we have a lot of really great questions, and I want to try and get to as many of them as possible. We will, we'll post the questions in the chat as well as we go, if you can. So the first question is, just wondering how this campaign would be applicable to Saskatchewan, Canada. We are in an injection use and would apply to my province. And then similarly, maybe we could talk about the opioid crisis in the U.S. and the fact that women are particularly vulnerable to drug use. How does U equals U address HIV transmission due to drug use risk, and especially injection drug use? So I don't know.
Well, we've actually addressed this a bit, actually quite a lot. In New York, as part of the New York Coalition consensus statement, that there needs to be more research on injection drug use. It doesn't. U equals U applies to sexual transmission, not to breastfeeding or for people who inject drugs. And it, that needs to change. And I think it does apply to areas in population. What's that weird noise? Did you hear that? Is that literally sounds like someone snoring? Do you hear that?
I know.
Okay.
I'm not
it's
sure. Yeah.
I hope
hopefully our
someone's not asleep on the
are still awake.
But
okay.
So I think it does apply in the sense that what we, the campaign can't solve everything. It's just focused on sexual transmission and people who have sex. But what we are seeing is that groups are saying we need more research, and they're rising up and they're demanding, and we're happy to work with those groups to say we need more research on breastfeeding. We know the author of the Swiss statement is actually working on a consensus statement on breastfeeding. So that's a really good question, and I hope that we're going down that road with the science to be more clear about it.
Okay. So just a reminder, if the presenters can mute their phone while they're not speaking, and then just unmute if you're going to jump in with the questions and the answers. Does anyone want to add to that before we move on to the next question? Okay, so one question is that is there any flyers or materials about this campaign to distribute? And I'll just let you know that yes, there are. We are going to be following up, with this. Everyone who is attending this or registered, and we'll be sending out a link to a web page that will include this recording. It will include the slides to this webinar. It will include links to Prevention Access Campaign, where you'll find all sorts of great resources, as well as additional links to other organizations and information around this campaign.
I think one thing that I just forgot about. I'm sorry, this came up in our New York State discussion with the State Department of Health. Is the drug people who inject drugs? Is that Charles King from Housing Works has worked very closely with the population, and there's studies that show that that sexual transmission is the prime route of transmission of HIV still. So people who inject drugs also have sex. So this does apply to them, and they should still know this information. That if they have sex, that they're and they're not undetectable, they should seek other forms of protection. So it totally applies to that group as well. It's just not to the form of transmission through injection drug use. Does that make sense?
Yes, thank you. Okay, so another comment came in saying, I was trying to explain U equals U to someone in Uganda recently, and his response was viral load tests are completely unreliable in his country, and he concluded U equals U is not available to those where lab work is not always available. Any thoughts I can pass along to him? And similarly, I believe we had another question from another participant, and I believe in Nepal, that said, they don't really, how does this affect people who don't really have access to viral load tests?
We get that one a lot too. I don't want to dominate the question and answers. Does anyone else want to take it? But I've answered that a lot for like a year. Does anyone else?
Yeah. So this is Ben. Let me at least jump in from a public policy and human rights perspective. And so yes, U equals U. Really, the foundation of that is having access to having one, access, and two reliable HIV viral load testing. That's a global priority set by both the United Nations and the World Health Organization. And yes, I want to value the observations from Nepal, from our participants from Nepal and Uganda, in so much as that there are many countries in the world where that viral load test is not yet available. So at the larger advocacy perspective, it's important to understand that U equals U is still relevant, if for no other reason than to try to make sure that all communities have access to this very important diagnostic test. It to me is second in importance only to the HIV antibody testing, and yet it has not been a priority until very recently. And even when announced as a priority, many countries are very slow to adopt. So yes, it's an area that we recognize that is unequally available around the world, increasingly becoming available, especially in Southern Africa. But there are many places where who have not yet been able to benefit from that technology.
Yeah, and I guess also one thing we've heard is that why should we? I guess the question is, do we want to withhold this information from people? And would there possibly be a group of people in Uganda? We actually work with William from Love to Love organization, who is using this information. We have, his memes all over our site. He's very active to stress adherence, and for you and for your partners. And then the other thing that we hope, and we're starting to see, is that people are getting together and saying, this is going to be the tool that we use for advocacy. This is what we're going to say to our health ministries. Is this doesn't just save our lives, but this also will prevent us from transmitting to other people. We need these tests. So there's stepping back. It can be very valuable in those environments, and we really hope so, and we want to do more sort of convening and bringing people together to figure out how we can be more helpful in those sort of hostile and also lesser resource environments.
Okay, thank you. So the next question is, asking, I'm wondering how we can share this in Nepal where people who are on meds are stigmatized and also not aware of these things, all of these things.
Well, I'm sorry, I didn't hear the question.
Oh, okay. It's someone from Nepal was asking, how that they can share this information in Nepal where people who are on HIV meds are stigmatized and not aware of this information. So hopefully, things like this webinar and the fact sheets and all the information that the Prevention Access Campaign puts out and partners can help provide the tools and information to to everyone here, and then those that you're sharing it with to share the information. But it is would be interesting to see. I don't know, Bruce, if you have any connections in Nepal.
No, we don't. But Jyoti works with us, is on our steering committee, and she's in India, and I know she would be, better equipped to answer from that region of the world. But the main thing is really that if an organization from Nepal sees this information, then we trust them to present it in a way that works for them. I mean, we will never, ever be gatekeepers. We will never, ever impose our views except provide science to other organizations and to help them in any way that we can. But it's really, in a sense, it's like, this is very much a grassroots, dirt roots situation where we went to the sort of the top roots to get the information, and we want to make sure it gets out to absolutely everyone in a way that makes sense for their communities. We're not in Uganda distributing it. Williams in Uganda, and Jyoti is in India, and so it's sort of this. That's really the way that it works, and hopefully. And then I'll wrap up because I'm rambling a bit. But hopefully this network of 280 plus organizations, 34 countries, that continues to grow. Our vision is that those countries, that we will share resources among the different countries. So we'll share not only the research and all the challenges, the common challenges that we face, because there's many common challenges that we've heard, but also sort of marketing materials and and support and strategies for how do you use this to advocate for diagnostics. Here's what they're doing in this country, and it might be relevant in another country in the global south. So we really want to be able to share and facilitate and be that kind of provide that kind of assistance, but never in terms of never being top down or gatekeeping, which is what we constantly come across. A lot of gatekeeping, and we are trying to break through that. It's hard to understand sometimes. But these are great questions. I appreciate them. Really, really good questions.
Yeah, and to that end, someone had a comment that they said that they've seen from messaging from different organizations that have signed on to the consensus statement sometimes differ, and that they've seen the wording will not or do not or cannot transmit HIV. And the question is, what, if any, was the deliberation process behind choosing this wording? And so maybe, Bruce, you're kind of answering that by saying that, you provide the information and then people... So I don't know if you want to elaborate a little bit.
Yeah, I can definitely elaborate on that, because we have worked on their own statements. A lot of the groups we've worked on, they've created their own consensus statements and also sign on to ours. And, so the do not is a lot less forward thinking. So based on studies, studies have showed that, people who are on effective treatment do not transmit HIV, where cannot is more definitive. So in the future, it's sort of like this isn't going to happen in the future. Do not is a bit more conservative. And the truth is there could be an outlier case someday. Cows can grow wings. Nothing is impossible. But in public health messaging, you need to be, you don't base public health messaging on the fact that nothing in science is impossible. But there are some folks who are more concerned about that and using things like zero risk. They're worried about that, which we understand because there's no zero risk in science. So they use do not, which is more, which is studies show that we don't transmit. And just in terms of that, there's no zero risk in science. I think people really need to be aware of that. When someone says to you the risk is not zero, respond to them. The risk is never zero in science. So if you go down that route, people living with HIV will forever, to infinity, be a risk. Whether they're undetectable, not undetectable, it's irrelevant because we'll constantly be a risk. So we have to let go of that. There's no zero risk in science. It doesn't matter. It's very harmful to this whole messaging and transition in the way we think of people with HIV.
That was awesome. May I interject? This is Maria. I wanted to ask a specific question to Dr. Ben Young, if it's possible.
Sure thing. Go ahead.
Okay. The thing is that one of the main things that I get asked over and over and over with people that want to join, U equals U, is that they say that being undetectable, yes, it's it lowers the virus in the blood, but what they talk about, or what their statement is that, and in the secretion, in the like, for example, and I'm sorry to be very specific, in the anal secretion, and fluids, semen and vaginal fluids, specifically that also what they say is the anal secretion. They say that when you're undetectable, they're really measuring the blood, but they're not measuring that. What is the response to that, Dr. Ben? Because I'm not a doctor.
Yeah. Well, thanks, Maria. I think I say it's the science simply says that there hasn't been transmission, and
okay.
I mean, I actually start with the earlier point first off, which is that, and it actually it's even a broader statement than U equals U, which is that single sexual encounters are not high risk. We keep using this term high risk. And it sets a table for everyone being worried about the smallest minutia of body fluid contact. Sexual exposure, even in someone not on treatment, is a low risk event for HIV infection. And so when one goes on HIV therapy, the amount of virus in that body fluid goes down by 99.99, sometimes even more %. So you're taking something that starts with low risk and making it astronomically low risk, and that's the starting point for that conversation. And then it's really, again, I go back to the partner study where there were 60,000 sexual encounters, lots of body fluid exchange, and zero transmissions when the partner was on treatment, and that's my response.
Thank you very much.
Great, thank you. The next question, and someone also just was asking this in the chat, so it relates to it. Are there any governmental agencies outside of the U.S. that have launched U equals U messaging campaigns? And Bruce, I know you can answer this, but I just wanted to let everyone know that we posted the link, and so did Bruce, to the Prevention Access Campaign and the U equals U website. So there's a community partners menu item that you can look, and you just, if you go back probably weekly, it's going to be, or updated, because there's always new people signing on. And then, so Bruce, I don't know if you want to add to that in terms of government.
Yeah, sure. In terms of government campaigns, we have the Washington, D.C. in the U.S., and New York in the U.S., and many other cities and states are poised to sign on, so you see a lot in the next couple months. And then outside the U.S., there are government-funded campaigns in the UK, in France, in Switzerland, and Canada, and I'm not sure about, a lot of the other places are more advanced, like in Denmark and the Netherlands, but I'm not sure if there are campaigns that are funded by the government agencies. But it's a good question and continues to grow all the time. And please check on our Facebook page for a big announcement on July 24th. We'll have a big agency signing on at that point.
Great. Okay, and before I move on to the next question, I know we only have a few minutes left. If our panelists are available to continue to get through all the questions, we'll maybe run a few minutes over, but for those that need to leave, I will also be sending out the link shortly to the post-test and for this webinar. And I just want to remind everyone, it's in these slides, but if you are sharing this information on social media, on Facebook or Twitter, to try to always use the U=U hashtag, and that way we can really continue to make that trend and raise awareness on that. So, okay, so quickly, the next question says, person with an undetectable viral load has an unsafe sex with another HIV-positive person with detectable viral load. Are there any chances of getting infected with drug-resistant virus?
Ben, do you want to take it?
Maybe
we've addressed that before.
Yeah,
let me get more credible from you.
Well, I'm not sure about that, but I'll accept that as a compliment. So the subject is really about superinfection with a second strain of HIV when one is exposed, to a different virus. And so first and foremost, we know that this can happen, although despite the many sexual encounters that positive people have, it turns out it's pretty uncommon. It's actually quite rare. So that's the first piece. The other thing that's relevant in that is that someone who's taking therapy, in essence, is taking pre-exposure prophylaxis to the other virus, and so that second virus has to be resistant to most, if not all, of the drugs that the person with the undetectable viral load is taking, and so we know that pre-exposure prophylaxis, which is a whole separate important aspect to dealing with sexual health and stigma. Pre-exposure prophylaxis works as long as someone's taking their meds. So someone who's taking HIV meds and has an undetectable viral load is taking their HIV therapies, which should also work as pre-exposure prophylaxis. So the risk of that second infection becomes very, very low. I'd hate to say zero because, it's at least once upon a time I thought of myself as a scientist. But I think that, again, it goes down to these, vanishingly low, negligible levels.
Yeah, we heard the same thing. The main thing is don't worry about it. Don't worry about it. It's not something, people, again, we get terrified about things like this. When you're living with HIV, you don't want to infect anybody. You don't want to transmit the virus. You don't want to put yourself at risk if you're undetectable. But basically what we've heard is it's never happened. There's no proof this has ever happened. And there's nothing to suggest that this will happen. If someone's undetectable, it's like having, PrEP on steroids. And so don't worry about it. I think what happens is when we say it's very unlikely, or even, that sounds okay, it's still possible, and we have so much heightened fear of transmission, and so much heightened fear of stigma that any tiny risk that we perceive, we think is a significant risk. And so I'd say, we don't need to worry about it, and that's what we've been told. And I certainly don't worry about it when I've had sex without condoms and been undetectable. And I've been working with these researchers for a long time as well. So like Ben said, Dr. Young said, it's not it's not something to take into consideration. It's not important.
Right. I think that's actually a more of saying it. So.
And I just want to kind of really re-emphasize this point, but with one of the comments from Bose, who's one of our global ambassadors in Nigeria and has been part of the Well Project for many, many years, and does amazing grassroots education all over Nigeria, especially with young girls in schools. But her comment is, I have been living in constant fear since the day I met my husband. He is negative, and I've been undetectable since 2003, just a few months after I started taking my meds. We have been married for over 10 years now, so from what I get from this presentation is I cannot transmit HIV to him. So, comments less question, but I think, I think the clear answer is yes, and you can't.
Yeah. I mean, I think it's a great question, and it's we also hear that a lot is, it's hard to sometimes accept. So people are like, will email us over and over again. Are you sure? Are you sure? Is this real? Is this real? And yeah, it's real. If you're taking your medicines, you're adhering to your medicine, and you're in care, you can't transmit HIV if you're undetectable. When you're undetectable, if you don't have viral load testing, then there's more of a risk that something could happen if you're not adherent. But typically, if you're adherent, your viral load isn't going to change. So that's what the message is from our our campaign. There may be a blip here, you did here and there, but if it's transient, if it just happens once or twice, it's not a big deal. So don't worry about it. But it's great. Yeah, it's great news, and hope that it's something that the caller can accept and integrate into her life and feel happy about.
Great, thank you. And I know we're past time, and one final question. And I think we covered this a little bit in the panel discussion, but maybe just it seems like it may be important to just reemphasize what is the most common question you hear about U=U when you tell people about it for the first time, or what are the common initial expressions of doubt or sources of contention? So, does anyone, Maria or anyone want to answer?
Is Gina on the line or Maria? I know you're out there advocating all the time, so we are too. But it'd be great to hear your experience.
I know Gina had to jump off. Maria, are you still available?
Yes, I'm here. Can it went in and out. Can I get the question again?
Sure. So what is the most common question you hear about U=U when you tell people about it for the first time, and what are the most common initial expressions of doubt or sources of contention?
Well, the question that I asked Dr. Ben is the question that I get asked the most, or the resistance that I get, which is, that viral load, suppresses the virus in the blood, but how about the other fluids? And now we got that response, so I'm going to use that response to answer to them. Also, why hasn't our provider talked to that about that to us? That's one of the main things. And I tell them, well, you have that conversation, show them all the information we have, and in the prevention campaign website, there a lot of information is there. And I just tell them, just continue having the conversations with the providers, because that's one of the main issues, not only in the USA, but around the world, that their doctors, they have never discussed being undetectable as being untransmittable. They've never had that conversation. A lot of the times they go and they ask the question, and the doctor tells them, no, you should continue to use condoms, and sometimes they get scolded. So I emphasize in having a good relationship with a doctor. If you feel like you are not compatible, you could always change to a doctor that's maybe more open-minded, and wait for that doctor to get comfortable enough. Because sometimes I understand the other side. I'm not attacking doctors or providers, but sometimes they have that fear too. The same fear that I had a year ago, and I'm not even a doctor, but I have the responsibility of a lot of people that follow me. And pretty much I have people that tell me, do you think I should get on treatment? And that's something they should be asking their provider. But that's the responsibility that I had, so that's why I could not jump right onto anything until I researched it, until I took my time, and then I could be sure of what I was trying to express. So that's basically the most that they tell me is that the doctor tells them no, or, about the other bodily fluids.
Thank you, Maria. And so I don't know, Bruce, does anyone else want to add to that, that answer, or before
mostly, fortunately we've been getting, when we speak to groups of people living with HIV, we just get tears and some anger, but why didn't they know before? And but mostly tears and happiness and just disbelief. And it's amazing to share that experience. We even had a PR firm in D.C. that was creating the campaign for Department of Public Health in D.C. talk to us about how in the focus group she told some people living with HIV and how meaningful that was for her. And one of the most meaningful moments of her life was to hear how the reaction. So mostly we've been now getting very positive, very, very positive reactions. Not as much. Yeah, I mean, there's a back history of negative reactions, but things are changing. So it's very encouraging.
Great. Well, I know we've lost Gina. She had to step off. She's doing another meeting right now, but I just want to thank our presenters so very much for all this amazing and empowering information. And I also want to thank our team, Olivia Ford and Jenna Conley, who have also helped prepare all the materials and information, the fact sheet that you'll receive links to, as well as this webinar. And all the participants. It has been a really great webinar. The information that's being shared and learned, and I know will go so far beyond just the participants that are here today. And we just want to thank you all. And we will be in touch in the coming days after we get the recording up on the website, along with the slides, the fact sheet, and a bunch of links to additional resources for you to review and share. So once again, thank you, everyone, and we look forward to your participation in the next webinar.
Thanks, everybody. Have a great day.
Thank you. Chris,
thank you so much. Thanks for having us.
Yes.
Chris, may I add
one
more thing before we leave?
Sure, please.
Yes, well, I just got something that I think all of us have to be very aware of, and it's called the Consensus Statement on HIV Treatment as Prevention and Criminal Law Reform. I'm going to put the link, and it's basically saying the reliance on viral load or compliance with medical treatment as basis to reform HIV criminal law possesses dangerous consequences for those who lack access to care. It also contradicts everyone's basic right to make healthcare decisions, including whether and when to get treatment without running afoul of the criminal law. Basically, this is something I believe we have to speak on because it goes against everything that we believe in, and I think that it was important to add that.
Well, it's Maria. I actually was involved with it. The Center for HIV Law and Policy brought us in on it, and I think in the context of criminal law, U equals U can be dangerous. I mean, we haven't talked about it as a team yet, but it can be dangerous if it's used as the main thrust of policy reform, because then you're saying that, well, people who are undetectable shouldn't be prosecuted, and people who are detectable should be prosecuted. They should be put behind bars, and so you've got this. It can be helpful on individual cases for defense, but it can be a problem on policy reform, and it will penalize people who don't have access to treatment and who are already neglected by the system. So it's a good document. I mean, really, but it does. I agree. It looks like it could be a complete contradiction in what we're saying, but we can talk about it offline. I appreciate you bringing it up.
Okay, perfect. Thank you very much.
Okay, well, with that, I am going to end the webinar, and unless anyone has any final comments, but I just, again, thank you, and we look forward to following up with you, and I'm sure there'll be a lot of more discussion around this, and, well, we want to keep the discussion going, so, all right. Thank you, everyone.
Thank you, Krista.
Bye.
Bye-bye. Thanks, Jenna.
Thank
Bye.
you.
Thanks.
Thanks.
Dad,
Thanks everybody at Well
Dr.
Project.
Young and Maria.
Bruce.
Thank you.
Thanks so much,
Appreciate it.
everyone. Pleasure to be part of this
All right.
webinar. Take good care, everyone.
Thank you. You
Bye-bye.
too.
Thanks.
Bye, everyone.